Hello everyone, my name is Dr. Zainab Vora. I have done my MBBS and MD in Radiology from the All India Institute of Medical Sciences, New Delhi. Today we're going to have an integrated discussion on choledochal cyst where we'll be talking about everything that can be asked to you from this particular topic. Remember, this is one of the most frequently asked topics from surgery and radiology in your PG entrances. So let's look at choledochal cyst. We start with a multiple choice question. So the question is, all of the following are true about choledochal cyst except the first option is it's associated with an anomalous pancreatico-biliary junction, also can be called ABPJ in short. The second option is it can present clinically as an abdominal lump with obstructive jaundice. The third option says that the investigation of choice is MRCP, and the fourth option is that the treatment of choice for all types is endoscopic sphincterotomy. So I'll give you a few seconds to analyze the options and come up with the correct answer. You can type it in the live chat if you're attending the premiere, or you can type it in the comment section if you wish. Alright, so let's analyze the question. So let's look at each of the options one by one and understand what they are saying. So the first option is that it's associated with an anomalous pancreatico-biliary junction. This is a true statement. This is a true statement which actually explains the pathophysiology, which is the hypothesis behind the occurrence of these choledochal cysts. So let's understand what we mean by this ABPJ. Alright, so let's look at a diagram and understand more about this. So anomalous pancreatico-biliary junction, as the name suggests, that the junction of our CBD and the main pancreatic duct which occurs is abnormal in these settings. Alright, so this diagram here is showing you the normal junction. So this is the normal common channel which will be formed after the union of the CBD and the main pancreatic duct, as you can see that it's going to drain into the major papilla. Now what happens when it is anomalous is that the union between the CBD and MPD occurs quite early. Alright, and can you all see that there is such a large common channel? Alright, so this large common channel has been referred to as APBJ, or an anomalous junction between the pancreatic duct and the biliary duct. Alright, now whenever there is such a large junction, what happens is there is higher chance of stasis of bile. Alright, there is higher chance of stasis which indirectly might result in a stricture. Alright, because of such stasis of bile, there might be some distal stricture which occurs, leading to the dilatation and formation of your choledochal cyst. Alright, so this is one of the hypotheses that such an accident, which if occurred congenitally or in utero, might result in the formation of these choledochal cysts. Alright, so this is just one of the hypotheses that has been proposed, that this is one of the frequent associations of choledochal cyst. Alright, so I hope this is clear. And just to give you one more extra edge pointer, radiologically on MRCP we can actually see that this junction and this common channel is quite long. Alright, so this is something that can be visualized. Anomalous pancreatico-biliary junction is something that can be visualized on MRCP or ERCP. Alright, and the definition, alright, the definition that we use for the dimensions of this anomalous common channel will be any channel which is more than 15 mm in length or more than 5 mm in diameter. Alright, so remember these numbers: a common channel more than 15 mm in length, more than 5 mm in diameter. Alright, so this is what has been defined as an anomalous pancreatico-biliary junction. Learning point: it has been considered as one of the hypotheses behind the occurrence of choledochal cyst. Alright, now going to the second important pointer, just a one-liner. There is a classification scheme which has been used to describe various types of these anomalous pancreatico-biliary junction, and that has been called the Comey classification. That is called the Comey classification. Alright, so just remember a one-liner. Comey classification is something which is to do with APBJ. Alright, with that background, let's look at the other options that we have. The next option focuses on the clinical presentation of a choledochal cyst, wherein it says that it can present as an abdominal lump with obstructive jaundice. This is indeed a true statement. Remember, choledochal cyst most often presents in younger children around 10 years of age. So most of the patients will be younger than 10 years of age. It is much more commoner in females than in males. Alright, so remember these about the demographics, that it occurs in children, more common in females. Now the clinical presentation. So there is a triad of clinical presentations that these patients can come with. One is an abdominal lump. The second, as you can see, is obstructive jaundice, and the third would be abdominal pain. So this typical triad is seen in somewhere around 30 to 40% patients. Alright, so remember this typical triad that choledochal cyst will present with. And out of these three, lump is the rarest feature. Alright, this is one of the least commonly seen features out of these three. Alright, so this is something about the demographic. We have done the clinical feature, we have done the hypothesis. Alright, now we go on to the diagnostic part. Alright, so we have two options, correct? Whenever we are dealing with biliary pathologies, I have either MRCP, which is magnetic resonance cholangiopancreatography. What is MRCP? It is nothing but a heavily T2 weighted image. Remember, it is a heavily T2 weighted image such that I will only be seeing structures which are T2 hyper intense, indirectly structures which have fluid. Alright, so in this sequence what will happen is I will only see the biliary radicals, while rest of the things will be all darkened, will be all appearing black. Alright, so this gives me a very nice non-invasive image. Alright, so you see how it is not invasive at all and there is no radiation involved, correct? Because we are dealing with MR. So MRCP, a heavily T2 weighted image, is a non-invasive modality which will show us the biliary anatomy, which will show us the choledochal cyst. Alright, the other option we always have will be ERCP, which is nothing but an endoscopic cholangiopancreatography, where we put in an endoscope and we will inject contrast. Alright, it's a retrograde cholangiopancreatography, which means that I will be cannulating the papilla and we will be injecting contrast such that the bile duct and the pancreatic duct gets opacified. Alright, so remember this involves X-ray. This involves fluoroscopy, which is a continuous video of X-rays. Alright, and it involves the use of iodinated contrast and it is invasive. So remember, ERCP is always preferred when there is a therapeutic role. Alright, whenever there is a therapeutic role in that diagnosis, only then will ERCP be preferred. Alright, so remember, in choledochal cyst diagnosis, our investigation of choice indeed will be MRCP. Okay, so this indeed is a true statement that investigation of choice is MRCP. Why so? Because endoscopy is not going to form our predominant treatment here. Our predominant treatment, in contrast to what our D option says, is not always endoscopic sphincterotomy. The treatment of choice actually will be the resection of the cyst. Alright, so we have a large choledochal cyst which is formed. So I would want to resect it and then do a Roux-en-Y hepaticojejunostomy. Alright, so this is the treatment of choice for most types. There is only one type for which the treatment will be endoscopic sphincterotomy. So to know that, we need to know the types of choledochal cysts, correct? So let's go into the most important part, which is our classification scheme of choledochal cyst. What is the name of this classification scheme? Very, very important. So remember, this is the Todani classification. This is the Todani classification of choledochal cysts. Alright, so if this is the normal schematic of your normal CBD, what will happen in type 1 is that there will be a fusiform dilatation. Can you see a single fusiform dilatation of the CBD? This is the type 1. 1 has further been subclassified into 1A, 1B and 1C. So let's quickly look, although this is not very important for MCQ purposes, but for a complete exhaustive coverage, let's quickly look at this. So type 1, remember, will have a complete fusiform dilatation of the entire extrahepatic biliary duct. Alright, entire duct will be completely fusiform dilated. 1B will be where there is a saccular dilatation. Alright, there is a saccular dilatation, it then becomes normal. Is this clear? So 1A would be fusiform, 1B would be saccular dilatation, whereas 1C में क्या होगा, that just below just below the insertion of the cystic duct, that is a common bile duct. Alright, only a common bile duct will get affected here. Is this making sense? So only the part below the insertion of the cystic duct gets fusiform dilated. Alright, so your part above the cystic duct, common hepatic duct, will remain normal here. Okay, so CBD only involved is the 1C type. Okay, so these are your 1A, 1B, 1C types. You don't need to know the subtypes. Just if you know that there is fusiform dilatation should also suffice. Okay, then we have the type 2 where we have a diverticulum. I have a diverticulum in the supraduodenal CBD. Alright, so you see this diverticulum outpouching of the CBD. This diverticulum is the hallmark of type 2 choledochal cyst. Alright, in contrast, type 3, we have a choledochal seal. Just at the insertion, I have this cystic dilatation. Remember the word, there is a cystic dilatation which is called choledococele. Alright, remember choledococele. Alright, so this is type 3. Then we go on to the type 4 where we have multiple strictures now. Alright, there will be multiple diverticulae and multiple strictures that I will be seeing in the type 4 type. Alright, so there will be multiple discontinuous skip lesion kind of cystic lesions. Okay, again 4 has been divided into 4A and 4B. Alright, what was earlier referred to as 4C is now been called type 5. Alright, so is this clear? So 4A and 4B is what we need to know now. So in 4A, we will have involvement of the intrahepatic ducts as well as the extrahepatic ducts. So these ducts and these ducts. Alright, so intrahepatic as well as extrahepatic ducts are now involved here. Whereas in your B type, we have exclusive involvement of extrahepatic. So a question can come to your mind that how is 4B different from R1? Correct, because both of them are involving the extrahepatic duct. Remember, here there will be multifocal, alright, there will be multifocal cystic lesions. Is this clear? So this is our 4A where I have multifocal cystic dilatations of intrahepatic and extrahepatic. In 4B, we have multifocal dilatations of the extrahepatic, and our 4C or our type 4 is where only the intrahepatic ducts are involved. Alright, is this making sense? Only the intrahepatic, extrahepatic completely normal. And what do we call this? What is the eponymous name associated with the type 5? It is our Caroli's disease. Correct? This is our Caroli's disease. Now, what is Caroli's syndrome? Is Caroli's syndrome the same? No. So remember Caroli's syndrome, if I add congenital hepatic fibrosis to Caroli's disease, it makes for the Caroli's syndrome. It makes for the Caroli's syndrome. Is this clear? Now, let's quickly go about the management. Let's quickly talk about the management options that we have. Alright, so remember, what did I tell you? The treatment of choice. Alright, the treatment of choice for almost all the types will be hepatic resection, alright, the resection of the choledochal cyst and Roux-en-Y hepaticojejunostomy. Roux-en-Y hepaticojejunostomy, except for type 3. In type 3, do you see only the distal part is involved? So this is where only our ERCP will suffice. Only an endoscopic de-roofing, alright, just the cyst is de-roofed and the sphincter is opened up such that the seal drains out, this choledococele drains out. So this is the only one where only ERCP, endoscopic sphincterotomy and cyst de-roofing will be the treatment, whereas for everything else we need Roux-en-Y hepaticojejunostomy, except for our Caroli's. What do you think? Can we do hepaticojejunostomy in Caroli's? No, because here intrahepatic ducts are involved. Correct? So here the management, the definitive management will be liver transplant. The definitive management will be liver transplant and nothing can be done surgically for these patients via hepaticojejunostomy. Alright, is this clear? So I hope the classification scheme, the sub-classification scheme and the treatment is clear to everybody. So that brings us to the answer that the basically the wrong statement here is our D option, correct, which is wrong, which is false. That is, treatment of choice for all types is not endoscopic sphincterotomy. It is only our choledococele, alright, which is gonna have this treatment of choice. Alright, is this clear? So now let's quickly look at a few images and try and see the classification scheme. Before that, let's understand the complications. Why is choledochal cyst so important? The most important ominous complication, guys, will be it's very high risk. It produces cholangiocarcinoma in 10 to 15% cases. Alright, so this most ominous complication, cholangioCA, and the worst part is even after treatment the risk does not completely go away. Although the risk is definitely reduced, but even after resection the risk persists and the patient is gonna need continuous surveillance. Alright, so very important that the risk persists even after surgery and warrants a long-term surveillance to see if there is ever the development of cholangioCA. So this was the other complication. So after that we have calculi formation. So anytime there is some sort of narrowing or some sort of stasis, we will have the calculi which will form in the dependent areas. Alright, so calculi formation, the next complication. Then again the same funda basically, that whenever you have some sort of obstruction, there will be the development of pancreatitis. There will be accumulation of the secretions of the pancreas in the main pancreatic duct, which will then induce our pancreatitis. Alright, so I hope the same pathophysiology of obstruction which leads to calculi formation, which leads to pancreatitis being a risk factor. Alright, then we have a complication when the cyst grows to a very large size. Very rarely, this is the rarest complication, it can even rupture. Alright, and there can be complete bile leakage. So cyst rupture, a potential complication, but quite rare. Alright, so I hope these facts are clear. This has all been tested in your PG entrances, so very important. Okay, now let's look at a few figures. Alright, so look here, guys. First, we try and identify the investigation shown. So now this is our magnetic resonance cholangiopancreaticography. So can you all appreciate how we are only seeing the T2 hyperintense structures? Everything else around it has been obscured. Alright, so remember our bile ducts will be the only things that we see. So it's a heavily T2 weighted image. What are we seeing here? So this is the biliary duct which is completely dilated. Can you see a fusiform dilatation? A fusiform dilatation of the CBD. This is the main pancreatic duct which is normal. This is the normal NPD, and these are the normal intrahepatic biliary radicals. Alright, so IHBRD completely normal. Intrahepatic biliary radicals basically completely normal. And what is this round structure? This is nothing but the gallbladder. Alright, so now can you tell me with this description where MPD is normal, intrahepatic ducts are normal, there is a single fusiform dilatation. How do we classify this? So yes, we classify it as a type 1 choledochal cyst. Alright, this will make for a type 1 choledochal cyst. Okay, let's look at the next figure. So again, this is again our MRCP image. Can you all appreciate this MRCP image? What are we seeing now? That now there is a dilatation, a fusiform dilatation of our extrahepatic biliary radicals as well as the intrahepatic biliary radicals. Is this clear? Our extrahepatic as well as intrahepatic, correct? You see that these are all so very dilated. When we compare it with our normal ducts, see how they are dilated completely. So again, this will form intrahepatic plus extrahepatic, makes for our type 4A. Alright, so this is our type 4A choledochal cyst. I hope this is making sense. These are some advanced questions that can be put to you in your entrances, where they can give you the image and ask you to further subclassify it. Alright, okay. And going to the most important type, the last type, where we have only involvement of our intrahepatic radicals. Alright, so you see that there is this complete fusiform dilatation. You see this marked dilatation of the intrahepatic radicals, and what we see in the center is, do you see this vessel, this white thing which is coursing in the center? So this enhancing thing, because what image is this? This is a CT. We know that the bones are white, it's a CT. The vessels are white, it's a CCT. So what are we seeing is that there are vessels within the dilated biliary radicals, and this has been referred to as the very important sign, which is the central dot sign. Alright, so the central dot sign, very typical for what? A type 5 choledochal cyst, or also called as Caroli's disease. Okay, so this is what our Caroli's disease will look like. Very important image for us to understand. There will be marked dilatation of IHBRD with a central vessel, which is the central dot sign. And if I add congenital hepatic fibrosis to this forms our Caroli syndrome. This forms our Caroli syndrome. And what will be the treatment of choice for this type? It will be a liver transplantation. Alright, the liver needs to be transplanted here. So very quickly, just a quick word. So we have already discussed the treatment is resection and Roux-en-Y for most types except for type 3 where we have a distal choledococele where we just need to do an endoscopic sphincterotomy and de-roofing of the cyst. Alright, and in our extensive intrahepatic involvement in our type 5 basically what we are going to do is a liver transplant. Alright, we are going to do a liver transplant for type 5. Okay, so that is the entire exhaustive coverage of our choledochal cyst. I hope this was clear to you. I hope everything made sense and all your questions from this topic will get answered. Thank you so much and I'll see you all again. Bye-bye.